10 things I would never do to my own face and the science behind them. There are 10 things I would never do to my own face, not because I'm perfectly disciplined. I'm an aesthetic doctor, not a skincare nun. But after years of treating patients and reading scientific papers that are considerably less enthusiastic than skincare advertisements, I have developed certain rules. Today, I'm not just going to tell you what I would avoid, I'm going to explain the evidence behind each decision. We will discuss irritated skin, misdiagnosed by ChatGPT, antibiotic resistance, mystery bleaching creams, tanning beds, filler-related blindness, online peptides, beauty filters, and one large randomized trial that may save you considerably more money than the latest anti-aging serum. Some of the evidence is strong, some are observational, some comes mainly from case reports because it would be unethical to deliberately test the danger in a clinical trial. That distinction matters. Science is not simply finding one paper that agrees with you. It is understanding how the study was designed, what actually it found, and how confidently we can apply the findings to a real patient. I'm Dr. Low Chai Ling, an aesthetic doctor at SW1 Clinic, and this is Skin Honestly, where beauty claims meet clinical evidence. Here are 10 things I would never do to my face. Number 10, I would never start multiple potent actives at the same time. A patient once came to see me with red, inflamed, and extremely irritated skin. She had been using several active ingredients, including salicylic acid, glycolic acid, azelaic acid, and vitamin C. She entered her products and symptoms into ChatGPT and concluded that she must be allergic to all of them. So in her mind, the verdict was clear. Salicylic acid, bad. Glycolic acid, bad. Azelaic acid, bad. Vitamin C, also bad. Her bathroom cabinet had apparently formed an alliance against her. But when we investigated her properly, the testing did not support an allergy to those individual ingredients. Once her skin had recovered, appropriate products were reintroduced carefully one at a time, used separately. They were all well tolerated and worked well for her. The problem was not necessarily any single ingredient. The problem was the cumulative irritation created when she combined several potentially irritating products. This illustrates an important clinical distinction. Allergic contact dermatitis is a delayed immune reaction to a specific allergen. Irritant contact dermatitis does not require an allergy. It occurs when chemical or physical exposure overwhelms and damages the skin barrier, producing inflammation. In simple language, allergy means the immune system has identified a particular substance as a problem. Irritation means the skin barrier has been pushed beyond what it can tolerate. Salicylic acid is a beta-hydroxy acid that can be useful for acne and comedonal skin. Glycolic acid is an alpha-hydroxy acid that increases exfoliation. Azelaic acid can help selected patients with acne, rosacea, and pigmentation. Vitamin C has antioxidant and pigmentation-related applications, depending on its formulation. Each ingredient may have a reasonable role, but when multiple acidic or potentially irritating formulations are layered together, especially at high concentrations or introduced simultaneously, the combined effect may increase burning, erythema, dryness, and barrier disruption. Even individually useful ingredients can become collectively intolerable. This is also why AI-generated skincare analysis must be interpreted cautiously. A chatbot can identify possible irritants from a list, but it cannot examine the morphology and distribution of a rash. It cannot independently distinguish irritation from allergy, eczema, rosacea, or another skin disorder. It may generate hypotheses. It does not perform a clinical examination. Evidence-based acne guidance recommends gradually introducing potentially irritating treatments such as topical retinoids or benzoyl peroxide. For example, with alternate day or short contact application in appropriate patients. If you begin 5 active ingredients together and develop a reaction, you also lose the ability to identify the responsible variable. This is not a skincare routine. It's a clinical trial with no control group and a very unhappy participant. Clinical verdict. If several products cause trouble when used together, it does not automatically mean you are allergic to every ingredient. Dose, frequency, formulation, and combination may be the real problem. Sometimes the ingredient is not wrong. The chemistry between the ingredients is wrong. And just like human relationships, perfectly nice individuals can become extremely toxic in a group. Number 9, I would never treat acne with the long-term antibiotics without a clear exit plan. Antibiotics can be valuable in acne treatment, The problem is not that antibiotics are inherently bad. The problem is using them incorrectly, indefinitely, or as the entire treatment strategy. Acne is not simply an infection. Its biology includes abnormal follicular keratinization, increased sebum production, inflammation, and the activity of Cutibacterium acnes. An antibiotic addresses only part of that process. Topical antibiotics such as clindamycin are generally not recommended as long-term monotherapy because bacteria can develop resistance. This is why clinical guidelines recommend combining topical antibiotics with benzoyl peroxide. Benzoyl peroxide has antimicrobial activity through oxidative mechanisms, and its use can help reduce the emergence of antibiotic-resistant organisms. Oral antibiotics also should not quietly continue for years without reassessment. They are generally used for limited periods in appropriate patients, alongside topical treatments that addresses comedones and supports maintenance once the oral antibiotic is stopped. Antimicrobial resistance is not merely an abstract hospital problem. Resistant organisms can develop on the skin, and resistance genes may be shared within microbial communities. There is another practical problem. If an antibiotic temporarily suppresses inflammation, but we never create a maintenance plan, the acne may return after treatment stops. The patient then concludes that the only solution is another antibiotic cause and then another. We have created dependency without disease control. For some patients, the correct next step may be a retinoid-based regimen. For others, hormonal treatment, isotretinoin, or investigation for an underlying hormonal disorder may be appropriate. The treatment depends on severity, scarring risk, medical history, pregnancy considerations, and the individual patient. Clinical verdict. I would not use antibiotics as an open-ended subscription service for my skin. An antibiotic should have an indication, a supporting regimen, a review date, and an exit strategy. Because if your acne plan is simply continue until further notice may arrive in the form of antibiotic resistance. Number 8. I would never use an unlabeled skin-lightening cream. I have treated patients who developed what appeared to be chemical burns after using unlabeled or inadequately labeled skin-lightening creams. Some of these products may contain strong acids or caustic bleaching agents in unknown concentrations. Acids are not automatically dangerous. Glycolic acid, salicylic acid, lactic acid, and trichloroacetic acid all have legitimate clinical applications, but concentration, pH, formulation, exposure time, and patient selection determine whether an acid creates controlled exfoliation or an uncontrolled injury. A professional chemical peel is selected and applied according to the patient's skin, the intended treatment depth, and the properties of the peeling agent. An unlabeled cream gives you none of the information. You may not know which acid it contains. You may not know its concentration. You may not know its pH. You may not know whether the product was manufactured consistently. And you may keep applying it because the burning has been marketed as evidence that the pigmentation is coming out. A chemical burn can cause prolonged inflammation, disruption of the epidermal barrier, and post-inflammatory hyperpigmentation. In darker skin types, the attempt to lighten one area can therefore leave it even darker. I've also seen patients develop thin, fragile skin after prolonged use of lightening creams containing potent topical corticosteroids. Corticosteroids suppress inflammation and can initially make the skin appear smoother or lighter. This immediate change may persuade users that the cream is working beautifully, but prolonged inappropriate use, particularly of a potent steroid on facial skin, can inhibit normal epidermal and dermal processes. Patients may develop skin atrophy, visible telangiectasia, easy bruising, steroid-related rosacea, and acneiform eruptions commonly called steroid acne. The tragedy is that early improvement encourages continued use while the damage develops gradually. Mercury is another concern. A 2022 systemic review examined 41 peer-reviewed studies from 22 countries involving mercury exposure from skin lightening products. Chronic mercury exposure may affect the kidneys and nervous system and can potentially expose other members of the household. The problem is not pigmentation treatment itself. We have evidence-based treatments for melasma and other pigmentary disorders. The problem is treating an uncertain diagnosis with an unidentified chemical at an unknown dose for an indefinite period. Words such as herbal, natural, and secret formula do not tell us whether the product contains mercury, corticosteroids, strong acids, or undeclared prescription ingredients. Secret formula is not a sign of exclusivity. It is the absence of informed consent printed on a jar. Clinical verdict. If I cannot identify the ingredients, their concentration, and the responsible manufacturer, I do not put the product on my face, because an unlabeled bleaching cream may not simply remove pigment, it may remove part of your skin barrier with it. Number 7, I would never use a tanning bed. Ultraviolet radiation can cause DNA damage, oxidative stress, and immunosuppression within the skin. It also contributes to collagen degradation, abnormal pigmentation, and skin cancer. A tan is produced when the skin increases pigment in response to ultraviolet exposure. It may be aesthetically desirable, but biologically it is a response to injury. A major systematic review and meta-analysis published in the BMJ found that sunbed use was associated with an increased risk of cutaneous melanoma. Starting indoor tanning at a younger age was associated with greater risk. A later systematic review found that the first exposure at an early age was associated with approximately a 47% higher relative risk of melanoma. Notice that I said relative risk. That does not mean 47% of tanning bed users will develop melanoma. Relative risk compares the incidence between exposed and unexposed groups. This is exactly the kind of distinction that disappears when a scientific paper becomes a dramatic social media headline. These studies are observational, so they cannot eliminate every confounding factor. People who use tanning beds may also have different patterns of sun exposure, but the association is supported by a convincing biological mechanism and evidence that ultraviolet radiation damages DNA. Enjoying the outdoors is good. Exercise is good. Holidays are good. The goal is not to live like a Victorian ghost. The goal is sensible protection, shade, clothing, hats, sunglasses, and appropriate broad-spectrum sunscreen on exposed skin. Clinical verdict. I enjoy sunlight. I simply do not confuse deliberate ultraviolet injury with wellness. A tan may last for several days. The DNA damage has a considerably less convenient cancellation policy. Number 6. I would never choose an injector primarily by price. I enjoy a bargain. Discounted shoes? Excellent. Half-price avocados? Proceed with cautious optimism. But when somebody is placing a needle near an artery connected to the blood supply of my eye, I do not sort the options from lowest price to highest. Dermal fillers are medical devices injected into complex three-dimensional vascular anatomy. One of the most serious complications is vascular occlusion, and this occurs when filler enters or compresses a blood vessel and compromises blood supply. Depending on the vessel involved, the consequences can include tissue ischemia, necrosis, and very rarely permanent visual loss or stroke. Systematic reviews of filler-associated blindness have documented cases involving different filler materials and anatomical locations. These reviews are largely based on case reports and case series. That means they tell us what has happened, but they cannot calculate the precise risk per injection. Underreporting makes the exact incidence even more difficult to establish. The complication is rare. The severity is why it matters. The facial blood supply has connections with the ophthalmic circulation. Under certain circumstances, injected material can travel through these vascular pathways toward vessels supplying the eye. That is why anatomy, injection technique, product selection, emergency preparation, and rapid recognition of complications matter. Before an injection, I will want to know what product is being used. Is it authentic and traceable? Who is performing the procedure? What is their medical training? Can they recognize vascular compromise? Do they have an emergency protocol? And do they know when not to inject? Good aesthetic medicine is not demonstrated only by knowing where to place the needle. It is also knowing when to put the needle down. Clinical verdict. The value of an injector is not demonstrated only by a beautiful result. It is demonstrated by the decisions that prevent a catastrophe and by their response if one occurs. Never choose an injector because you trust their ring light. Choose one because you trust their clinical judgment when the ring light is off. Number 5. I would never laser a pigmented lesion without first establishing a diagnosis. Brown spot is a description. It is not a diagnosis. A pigmented lesion may be a solar lentigo, seborrheic keratosis, melanocytic nevus, post-inflammatory hyperpigmentation, melasma, or melanoma. These conditions do not share one treatment pathway. Published case reports and case series have described melanomas diagnosed after laser treatment of lesions that were initially believed to be benign. This type of evidence cannot tell us how frequently that occurs. It does, however, identify a serious clinical failure mode. Laser treatment can partially remove visible pigmentation without providing tissue for histopathological examination. It may alter the lesion's appearance and potentially complicate subsequent assessment. For suspicious melanocytic lesion, the priority is diagnosis, not cosmetic disappearance. I pay particular attention to change over time: asymmetry, border irregularity, multiple colors, increasing size, bleeding, or a lesion that looks unlike the patient's other moles. We must also remember acromelanoma, which may appear on the palms, soles, or around the nails, and may not resemble the stereotypical image of sun-related melanoma. Not every brown spot requires a biopsy, but every lesion should be appropriately assessed before someone attempts to erase it. An app or a salesperson at a beauty counter should not provide the final verdict on a changing mole. Clinical verdict. Never erase the clinical evidence before establishing what it means. Before removing a spot, find out what story it is telling. Number 4, I would never inject an online peptide without knowing exactly what is in the vial. Let us talk about GHK-Cu. GHK-Cu is a naturally occurring copper-binding tripeptide composed of glycine, histidine, and lysine. It has attracted attention because laboratory and animal studies suggest possible roles in wound healing, fibroblast activity, collagen synthesis, and the modulation of inflammation. That sounds exciting, but here's the important distinction. Interesting biological activity is not the same as convincing clinical evidence that repeatedly self-injecting GHK-Cu will rejuvenate healthy human skin. Much of the frequently quoted evidence comes from cell cultures, animal models, wound healing research, or topical applications. Those findings cannot simply be converted into an effective and safe self-injection protocol for facial rejuvenation. The route matters. The dose matters, the formulation matters, sterility matters, and most fundamentally, the vial must contain the substance stated on the label. I had a patient who told me she had been injecting a product purchased online and marketed as GHK-Cu. She had been injecting for approximately 3 to 4 months because she hoped it would improve her skin. She saw no meaningful improvement, so eventually we sent one of her vials to a laboratory for analysis. And guess what the laboratory found? No detectable GHK-Cu. The sample contained only what appeared to be a bulking of filler material. She had spent several months injecting an unidentified preparation that did not contain the active ingredient she believed she had purchased. Fairy dust would almost have been an upgrade. This illustrates the larger problem with gray market injectable peptides. A label is not proof of identity. A stated dose is not proof of potency. Research grade is not the same as pharmaceutical grade, and a certificate of analysis displayed on a seller's websites does not necessarily establish that the vial delivered to you came from the tested batch. Even confirming the presence and purity of a peptide would not prove that an injectable preparation is sterile, free from endotoxins, stable after transport, or safe for repeated human administration. Product quality has several separate dimensions. Is it the correct molecule? Is the dose accurate? What impurities are present? Is it sterile? Does it contain bacterial endotoxins? Has it degraded during storage? And is there credible human evidence supporting this route, dose, and indication? A product can pass one question and fail the 6 others. This is not an argument that all peptides are nonsense. Many established medicines, including insulin and GLP-1 receptor agonists, are peptide-based. Problem is not the word peptide. The problem is taking an inadequately studied substance from an unverified supply chain and injecting it into a human being. Clinical verdict. I would never inject a product simply because the molecule sounds scientific and the seller provides an impressive-looking PDF. Before asking whether a peptide works, ask a more basic question. Is there actually any peptide in a vial? Because if the label says GHK-Cu and the laboratory finds no GHK-Cu, you're not biohacking, you're participating in an involuntary placebo trial with a needle. Number 3. I would never have a major aesthetic procedure during an emotional crisis. This is not because every person seeking cosmetic treatment has a psychological disorder. Most do not. However, Body dysmorphic disorder or BDD is more common in aesthetic and dermatological settings than in the general population. One systematic review estimated a weighted prevalence of approximately 1.9% among community adults compared with 13.2% in general cosmetic surgery settings and 9.2% among cosmetic dermatology outpatients. A more recent meta-analysis examined 65 studies involving more than 17,000 aesthetic and reconstructive plastic surgery patients. Screening is therefore not an insult. It is part of responsible patient selection. BDD involves an intense preoccupation with perceived defects that may appear minor or be unnoticeable to other people. Cosmetic treatment does not address the underlying disorder and may not resolve the distress. Even without BDD, acute heartbreak, grief, humiliation, or cruel comment can temporarily alter how we evaluate our appearance. A tiny feature can suddenly feel like the reason everything in life is wrong. It usually isn't. A responsible practitioner must sometimes say, "Let's wait." Not every consultation needs to end with a transaction. Clinical verdict. I would not make a permanent or difficult to reverse decision about my face during a temporary emotional crisis. Sometimes, not today is the most ethical treatment plan. Botulinum toxin can soften a frown line. It cannot make your ex develop emotional intelligence. Number 2. I will never use a beauty filter as my treatment plan. Beauty filters are no longer simply improving lighting. They can enlarge the eyes, reduce nasal width, elevate the brows, sharpen the jaw, increase lid volume, and remove all visible skin texture simultaneously. A 2024 systematic review included 25 studies and more than 13,000 participants. It found associations between social media exposure, body dissatisfaction, and greater consideration of cosmetic procedures. The important word is association. These studies do not prove that filters directly cause body dysmorphic disorder in every user. People who are already concerned about their appearance may also use filters more frequently. But the direction of the evidence is concerning, particularly when altered images become the reference points patients bring to consultations. Camera optics create another distortion. A close-range photograph can exaggerate central facial features compared with viewing the face from a more natural conversational distance. So if you dislike your nose only in a close-up photograph taken with your phone held 20 centimeters from your face, the problem may partly reside in focal distance, not in your anatomy. Pores are also normal. Facial asymmetry is normal. Skin texture is normal. A line appearing when you smile is evidence that your face moves. It is not evidence that your face has failed. Aesthetic treatment can help suitable patients achieve realistic improvements. It should not force a human face to compete with software. Clinical verdict. Treatment should be planned using anatomy, proportion, clinical assessment, and realistic goals, not software-generated facial architecture. If an app invented the defect, your face may not need to provide the solution. Number 1, I would never invest in anti-aging treatments while ignoring sun protection. This is number 1 because it is supported not merely by laboratory evidence or an observational association, but by a randomized control trial. In a landmark Australian study published in the Annals of Internal Medicine in 2013, 903 adults younger than 55 were assigned to daily broad-spectrum sunscreen use or discretionary sunscreen use. The researchers evaluated skin aging using silicone impressions from the back of the hand. Importantly, these were graded by assessors who did not know which treatment group each participant belonged to. After 4.5 years, the daily sunscreen group showed no detectable increase in skin aging. Overall, skin aging was 24% lower than in the discretionary use group. The study had limitations. It was conducted within one Australian community. Some outcome data were missing, and behavior inside a clinical trial does not perfectly reproduce ordinary life. But it remains unusually strong evidence for a skincare intervention, prospective, randomized, and assessed over several years. Compare that with some cosmetic products promoted using 20 participants, no proper control group, 8 weeks of follow-up, and a questionnaire asking whether their skin felt more radiant. Ultraviolet radiation contributes to collagen breakdown, pigmentary change, and skin cancer. Sunscreen is not magic. It does not block all radiation, replace protective clothing and shade, or prevent intrinsic aging. And the best sunscreen is not automatically the most expensive. It is a broad spectrum product that you apply adequately and consistently. We will enthusiastically discuss lasers, injectables, exosomes, polynucleotides, and ingredients whose name sounds like rejected Marvel characters. But sunscreen? Too sticky. Clinical verdict. If an anti-aging routine excludes photoprotection, it is not an evidence-based strategy. It is a very expensive hobby. So conclusion, those are the 10 things I would never do to my own face. I would not introduce potent actives simultaneously. I would not use antibiotics for acne without a supporting regimen and an exit plan. I would not use an unlabeled skin-lightening cream. I would not use a tanning bed. I would not choose an injector primarily by price. I would not laser pigmented lesion before establishing a diagnosis. I would not inject an online peptide without knowing exactly what is in the vial. I would not make a major aesthetic decision during an emotional crisis. I would not use a beauty filter as my treatment plan. And I would not spend heavily on anti-aging while ignoring sun protection. The larger lesson is that evidence has a hierarchy. A randomized controlled trial can provide stronger evidence of causation than an observational study. A systematic review may provide a broader picture than one isolated paper. Case reports cannot establish how frequently a complication occurs, but they can alert us to rare and serious risks. Laboratory research can identify an interesting biological mechanism, but biological plausibility is not the same as proven benefits in living human beings. That final sentence alone could eliminate approximately half the beauty industry. I want to hear your beauty confession. What have you done to your face that you would never do again? Send it to Skin Honestly. I may feature the most educational stories anonymously in a future episode called Beauty Crimes We Survived. So follow this podcast and share this episode with somebody whose skincare routine contains more active ingredients than a pharmaceutical warehouse. I'm Dr. Low Chai Ling. Question extraordinary claims, respect ordinary skin, and remember, your skin is an organ, not a group project. Until next time.